We're just shuffling everybody back in the room here, Janet. Just a second. All right, well, welcome back. We will get started here with our next session. Hopefully for those who are putting us online, so this is a virtual presenter, so hopefully it'll sound better because Janet's all by herself in her room, her special room, with her own mic. So it'll be a little bit better sound this time. Again, put any questions you have in the comments. There is a video part of this that we're going to try to make work that doesn't work greatly with the platform, so we'll try to make it visible to everybody when it comes time. But I will turn it over to Janet and let her take it away. Janet, you're still muted. Nope. Stand by, we have audio technical difficulties.
Now,
Try again.
Sean, can you hear me?
Yep, there you go.
Okay. I've got a green microphone, so I assumed I was on, but okay, let's keep going. My name is Janet Taylor. I am originally from Southwest Missouri. However, I am broadcasting from Southeastern Oklahoma right now. So thank you for having me again. I love this. And this is one of my favorite new topics to give. And this is called Special Delivery, Caring for the New Mom in the First Hour. Now, I do not see my chat box from my screen. So if there's any questions, comments, Sean and Liz and a bunch of others are monitoring, they can stop me at any time and I can answer questions on the fly if you'd like, okay? So let's get started. Here we go. So all material, graphics, pictures, videos used in this presentation is for educational purposes only. I got it from the internet, but I used it under the fair use law for educational purposes only. I'm not copyrighting any of this because it's not mine to copyright. So for the rest of this program, I'm going to cover the first 24 hours after a delivery, specifically the first hour, but definitely the first 24 hours. These scenarios are assumed to be vaginal home deliveries because hospitals are now required to keep a mom who has had a vaginal delivery in their care for at least 24 hours. And C-section moms usually have to stay in for about 2 to 3 days to recover. So this is what you would see in the first hour to 24 hours after a delivery. Now, I will also explain to you a couple of the other things that go on, but the reason why this came up, this topic, was because I've taught childbirth forever. But once the kid comes out, there's a little bit of newborn care, but that was it. That was all that we really were taught. And then I've got people coming to me saying, what do you do the hour after? What do you do if mom is bleeding too much? What happens at this? And I realized we haven't done any follow-up care with this. The reason why this came about also was because of the huge increase in home deliveries, whether elective or unexpected. We had a huge surge of these in the last 3 years, especially. Some women just, have babies very quickly and they come out wherever they happen to be standing. But CDC released last year, 2 years ago, that home deliveries skyrocketed in 2020 and 2021, especially because of the pandemic. You know, there were so many restrictions for visitors. Moms were told you can come in and have your baby, but a lot of hospitals are like, no, no birth partners, no husbands, no baby daddies, no nothing. Well, moms didn't want that. They wanted this to be a family event, so they opted to deliver babies at home. So just a quick review on the changes in the body during pregnancy. During the first trimester of pregnancy, your mom's blood volume increases by 30%. And this is in exchange for growing a baby, you need more blood supply. It's also to help thicken those uterine walls with blood so that it kind of builds a baby cushion. And it also prepares mom's body for some blood loss after delivery, which is totally normal. The uterus goes from the size of a lemon to the size of a watermelon over the course of 9 months. Hormone levels surge as pregnancy progresses. And this, we get the mood shifts and we get all kinds of things going on. It's not only emotions that go on with hormones. We have other hormones in our bodies that do things physiologically to our bodies. Our joints loosen by a hormone called relaxin. Our stomach and intestines slow down digestion. All these things happen over the course of the 9 months. So fundal height, I mentioned that the uterus starts out the size of a lemon and it goes to the size of a watermelon over the course of 9 months. Well, we can see how far along mom is by assessing a fundal height. Now, this is on moms who don't know they're pregnant, they didn't have prenatal care, or maybe they just can't talk to us. Maybe they are unresponsive. So at 12 weeks of pregnancy, the uterus clears the pelvis. Those very top pelvic bones is where that uterus actually gets up to that level. Now, the fundus is the top part of an organ. Your stomach has a fundus, your liver has a fundus, your uterus has a fundus. So if you can just imagine putting your finger on your forearm and just kind of pressing it, it's very muscular, your forearm is, and it's got some bounce. That's what a fundus is on a uterus. So if you have a pregnant mom, her fundus is going to be rising up and out of that pelvis as the pregnancy progresses. When that fundus is at about 20 weeks or halfway through the pregnancy, that's going to be at the level of the belly button. So if you take the palm of your hand, rub it along mom's belly, you're going to feel a firm ridge right along the level of the belly button. Then you know she's about 20 weeks along. Now, for every centimeter above that 20-week measurement, it equals about 1 week of pregnancy. Now, this is in a single pregnancy. Twins, triplets, you're out the door with that, okay? What I have in my hand, my fingers are about 1 centimeter in width, so it works really great. If my pinky is on my belly button and my fundus is right here, I know I'm 21, 22, 23, 24, about 24 weeks pregnant if my fundus was this far above my belly button. Now, once you get your fundus right below the xiphoid process, you can pretty much assume mom is term. You're not going to get that 40 weeks, that 20 centimeters above the belly button, because when you start getting to about 37, 38 weeks, baby starts settling down in that pelvis. So your fundus will actually drop. So if you've got a fundus that's right underneath mom's xiphoid process, you can assume she's term. So other things that happen to the body during delivery, pregnancy, the very end of pregnancy and the beginning of the delivery process, is Pitocin is released from the posterior pituitary, which is in the back of your brain, and it is sent to your cervix, and your cervix is starting to soften, okay? You start having these practice contractions called Braxton Hicks that start about 20 weeks of pregnancy. They're not true contractions, they're practice contractions. So you'll notice after 20 weeks of pregnancy, you kind of get a little crampy, but it doesn't hurt, it's just annoying. And it's very erratic, extremely erratic. So when you start getting serious about having this baby, that Pitocin is released and your uterus starts giving a little squeeze. Not uncomfortable yet, just a little squeeze. And you can see here in the diagram, I realize you can't see my cursor, but I'll explain. Top left, it says the cervix, and that's that lighter pink. It's long and it's closed, okay? It's not going anywhere for a while. Now, as that uterus softens, as the cervix softens and that uterus starts giving some contractions, that cervix will shorten this way, okay? And then the opening will get wider this way. okay? So this happens all throughout the delivery process, okay? A contraction comes, that cervix gets a little softer, opens up, gets a little shorter. Another contraction comes, the cervix gets softer, shortens, and opens up. So this was taught to me. This isn't my trick, although I think it's really cool. A couple different things here, okay? Everybody make a fist. Let me put myself on camera so I can see what I'm going to show you here. Okay, so everybody make a fist like this, all right? Nice tight fist. Take your finger and try to poke it in here. This is literally what a cervix feels like when it is not ripe, and that's what they call it, is a not ripe cervix. It's not dilated, it's not effaced, it's pretty firm, okay? So then the next one is I want to show you what a cervix feels like as far as ripeness, and that's what we call it, is a ripe cervix, okay? So if you touch your chin like this, okay, everybody touch your chin, tap it, that's what an unripe cervix feels like, okay? Now, as that cervix starts to soften, everybody touch your nose. It's softer, it's got a little bit of give to it, okay? And then as that cervix is completely dilated and effaced and thinned out, touch your lips. They're thin and they're really, really soft and squishy. This tells us that mom is fully dilated and ready to go. And this is what that picture on the top right says, cervix fully dilated. This just lips now, okay? You've got lips that are thin and very pliable. So there are actually several stages of labor. Stage 1 is the labor part, and there's 3 different parts to stage 1. Stage 2 is the birth, and then stage 3 is the delivery of the placenta. So I mentioned early on, you start having some contractions, your cervix gets a little bit softer, mom is a little uncomfortable, but not bad. She can still talk through contractions, you know, she can still walk, she can kind of do things, you know, it's uncomfortable, but that's about it, okay? Active labor is from 6 to 8 centimeters. She's starting to get a little cranky now. Things are coming more regularly. The contractions are stronger, okay? Transition, and that is the last stage before that baby starts coming on down that birth canal, and that is contractions are intense. They last about a minute in length, and they are about a minute apart in length. Mom's really cranky now. This is not comfortable at all. Stage 2 is where that kid actually starts coming down the birth canal. And then of course, stage 3 is the delivery of the placenta. Now, depending on where baby is, most babies are born face down, okay? And what actually happens is there's 4 cardinal movements of delivery. There used to be 7, they decided there's 4. So baby's actually moving down, rotating, moving down, rotating the other way, flexing, and then coming out and then doing another rotation before they come out. The vagina is a very, very muscular organ. So first time babies tend to take a while because the muscles are creating a canal like this. So there's muscles kind of cross-threaded all around the diameter of your vagina. And that kid's head that is this big is having to push through and go through these very, very, very strong muscles. So mom's pushing that kid's head before it came down to the cervix was nice and round. Now it's having to actually kind of push through and it molds to the shape of the vagina, okay? Once baby comes out, then it will rotate once more and it will be delivered. So this is crowning. People would look at this who haven't done OB and they're like, oh my gosh, that kid's coming out any second. I'm telling you now, if this is a first time baby, mom's probably got another few minutes of pushing at least before that kid's head comes out. And like, oh my God, look how much head there is. Yes, but that kid's head is still having to mold against that vagina and mom is still pushing. The bottom left picture, you can see they're doing a little bit of support. Mom's pushing, but there's not a lot of head showing yet. She's probably got, if this is a first time baby, I would say she's probably got another 3 or 4 minutes at least of pushing. So once the baby's head comes out, you notice here, they're kind of supporting mom's perineum. When the kid's head actually starts emerging, you can put your fingers very gently on either side of baby's head, and just keep it from popping out too fast, because mom's pushing hard. That kid's head can pop out really fast. We want to try to avoid that, because that sudden release of pressure can cause the veins in baby's head to shear just a little bit. That's kind of a normal birthing process. We just don't want the kid to come out too quick. Check for a cord. Okay, so their head's out, nothing else is out. Check for a cord, unloop it if you need to. Once that head is completely delivered at the neck, the baby will look to one side or the other. Okay, so this is that rotation. Okay, you can't tell what side the kid's going to roll to. You can't guide the kid. The kid's shoulders are spinning against the axis of mom's pelvic ring. Just let mom do the pushing, and baby will turn one way or the other, and we're just going to guide it. Okay. Press down on the top shoulder. That would be the shoulder nearest to mom's pubic symphysis, and the baby will come right out. Here's something new. Okay, once the baby comes out, you put it face down on mom's chest, and I'll explain why here in just a second. Okay. So here we've got baby, and you see that bulb suction syringe. So we've got baby out, and they have that bulb suction syringe, which we've been taught to do for years and years and years. The new guidelines, according to the American College of Obstetricians and Gynecologists, say no suctioning. People are like, what? That's all we've ever done. Well, what I said was take baby out and put it face down on mom's chest, right? We've got a bunch of towels or blankets right here. That's the most natural way of doing this. The stuff in the baby's mouth will roll out by gravity onto the towels or blankets. You can go ahead and dry stimulate baby, and you can mop their face and get that stuff out. You can also take a towel like that, swab it around your finger, and put it in their mouth and milk their nostrils. That should be enough to stimulate baby to breathe. The reason why we don't suction anymore is because we never did it right to begin with. We stimulated gag reflexes. The tip of that bulb syringe was raking up against the baby's hard palate, causing a lot of injuries. And really, if you've ever worked OB, most OB nurses will admit, well, yeah, even on the juiciest kid, you'd suction their mouth and nose, and you'd only get maybe a teaspoon or two out. That's all we would get. It was the stimulation and the drying that caused that kid to breathe. So here we have the meconium stained amniotic fluid. Okay, so they have decided, meconium or not, vigorous or not, don't suction. However, I will give you a little tidbit. If it is meconium stained amniotic fluid, we were taught, don't stimulate, get the kid out, suction, suction, intubate, suction, suction, suction some more, and then you might think about drying and stimulating. They're saying, meconium or not, treat all these kids the same. You bring them out, you dry them, you stimulate them. Anything that's in their mouth will either roll out, or they will swallow it back down and they will clear their own airway. The only time we are advised to do aggressive suctioning or bagging or ventilating is on those non-vigorous babies that are premature who need some respiratory support. So here we've got a home delivery. We've got baby coming out. We've got perineal bulging. They're doing a little bit of support on the picture on the right. That's just called perineal support. That's just a warm rag that they're putting up against mom's perineum just to kind of help relax and kind of take the sting out of it. Baby's out, head is out. On the picture on the right, you're going to see that external rotation. This particular kid decided to turn to mom's right thigh, and they're going to go ahead and just support baby. They're going to press down on that shoulder, and the kid comes out. So this, again, we're not going to suction anymore, but I haven't got any new pictures to reflect the new updates. But here you have baby coming out. This baby turned to mom's left thigh, and they're doing a little bit of suctioning. Now the next slide is the video of a live birth. The guys on the other end are going to try to get this to work. If not, it's not a big deal.
Okay, excellent. All right, keep it coming. Let's bring that baby underneath that pubic bone. Just a nice gentle push. Good job. Okay, good job. Just breathe.
The baby's nose and mouth are suctioned.
It's a cute baby. Okay, we got one loose unical cord, one little cord very loose around the babies. Okay, without pulling, I want you to give a little push. Okay, good. You can stop now. That's it. And we're just going to gently guide the baby out. And it's a, what is it? It's a girl.
So you notice the baby, yes, they suctioned the baby, but even while the baby was being born, as soon as that kid cleared the vagina, it took its own breath. It didn't need to be suctioned necessarily. So we're going to position them on mom's chest, dry them, keep them warm, make sure and keep them warm, okay? If they aren't vigorous, okay, that baby in that video was vigorous. She had good muscle tone. She was pissed off. She was giving a cry. If those kids aren't like that after 1 minute of drying and stimulating them, check their sugar. If they are small for gestational age, which is SGA, check their sugar. If they're large for gestational age, or LGA, check their sugar. If mom has been diagnosed with diabetes during pregnancy, check the sugar, okay? Note the time of birth and the county the baby was born in. We're going to assess the baby, obtain APGARs, and keep them warm. Best place to do this is on mom or dad's chest. Okay, we'll give them a preliminary mopping, get all the major goobers off, put them right on bare skin, and then cover them up with a towel. Put a little hat on their head, or put the towel over their head also. Babies who are put up against their mom or dad's chest get warmth from the skin. Their little ear is up against, if it's mom, the same heartbeat it's been listening to for the last 9 months. It's near the breast, so mom can breastfeed easily. It's just so beneficial. They now have this as a national standard for all babies, at least the last, I don't know, 8 or 9 years at least, nationwide. It's standard. You kids born, you dry them off, preliminary, maybe put a diaper on them, you put them right on mom's chest, and that baby will stay there for at least an hour while mom recovers. We can do weights later, we can do shots later, we can do eye ointment later, we can do all that stuff. Any baby care that needs to be done immediately can be done right on mom's chest. So skin to skin care benefits, the baby cries less often, their temperature is body temperature is maintained better, they get better digestion and weight gain just by being on mom or dad's chest. They develop a stronger immune system, they stabilize their heart rate and respiratory rate, and they have better brain development. It's a win-win for mom also. There's more positive bonding, there's improved breast milk production. The bonding comes from the release of oxytocin or pitocin from your posterior pituitary. Remember, during labor and delivery, it's released also when you feel love for something. That's why it's called the love hormone. Our oxytocin levels go up when we fall in love. So back to mom, it reduces postpartum bleeding because that's helping her uterus to clamp down better. And it reduces the incident of and severity of postpartum blues, depression, or psychosis. APGAR scoring is done at 1 minute of birth, 1 and 5 minutes of birth. Okay, so the first minute you are given is to dry that kid off, stimulate it, get it to breathe, and get it to cry a couple times. You've got 1 minute, and that's plenty of time. At 1 minute, you're going to assess baby's heart rate, respiratory rate, their muscle tone, their reflexes, their gag reflex, their cough, their sneeze, and then their skin color. Do that again at 5 minutes, and it better have improved. The perfect score is 10. No fresh newborn is a 10. I will tell you that right now, because most babies are born a little off color, and that's totally normal until they get used to this atmospheric pressure. So then the new guidelines, and new being like 2016, the new guidelines are suggesting that we don't clamp the umbilical cord immediately. Again, people who have been in this job for a while go, wait, what? We have to. We were taught, deliver the kid, clamp, cut. That's what we were taught. Well, then somebody asked, why were we doing that? It's just always been done. And I'll tell you, it's been done for about 80 years. You see, back in the 20s or 30s, it was popular for moms to get nitrous oxide or gas, and they would breathe in this stuff. It would give them complete relief from labor pain, and the docs would reach up there with the salad tongs and pull that kid out. It's called a high forceps delivery. Moms would wake up a few minutes later off the nitrous, and they'd be fine, but babies were getting gas too because the cord's still there. You know, they are still getting what mom gets. So they decided, okay, let's give mom gas, pull the kid out, and then clamp, cut so they don't get any more nitrous. Nitrous wears off pretty quickly, So there wasn't as bad of an incidence of having to resuscitate these kids, but that's why we've been doing it. Even after nitrous has been eliminated from childbirth, we were still doing it. So the American College of Obstetricians and Gynecologists recommend delayed cord clamping. Moms who have had sedation, usually it's just Stadol or Nubane. If they have a natural birth, if they have vaginal, if they have C-section, if they have an epidural, doesn't matter. We're going to delay cord clamping for at least a minute. And there are some benefits to this, okay? So at least a minute, even a couple of minutes is even better, because in the first minute after birth, when that cord is still pulsating, babies get about 80 mils of blood in that first minute, okay? That keeps them from becoming anemic, because always before we were clamp, clamp, cut, they're not getting that 80 mils of blood. Babies were anemic. So if we delay for at least 1 minute, babies are getting an extra 80 mils of blood. The initial breaths by that newborn actually facilitates blood flow to the baby for a few more seconds to give that baby an additional bolus of blood so they can oxygenate. And then, because they have that extra blood, they have physiologic iron stores, they have better brain development, all from delaying cord clamping. Now, American College of Obstetricians and Gynecologists say 1 minute. Actually, World Health Organization recommends up to 3 minutes. So when you do decide to clamp, okay, a couple of tricks. The bottom right picture, you can see baby's pink skin, and then the start of what's called Wharton's jelly. It's that pale, sticky, yellowish, creamy looking thing, okay? When you clamp as far away from the pink stump as you possibly can. Some books say 2 and 4 inches, some books say 3 and 6 inches. That's fine, longer the better, because it's always better to measure twice and cut once, right? We can always cut it back later, but always measure from the end of the pink stump on. Don't measure the baby's actual belly, because that's actual live skin that they need to have, absolutely. So now there's this movement, and it's not new, it's an old movement, but it's called umbilical non-severance or lotus birth. And this is where you not only delay cord clamping, but you don't do it at all. You let the cord dry up and fall off naturally. So this is a popular thing. Parents who don't really feel like cutting a cord is natural. In olden days, in primitive times, you did this because there was nothing else to do. You either kept the placenta with the baby, or you cut it or chewed it apart in animal world, and you buried that placenta so it wouldn't draw animals. Well, now they're like, we don't want to clamp the cord, we want it to fall off naturally. And that's fine, you can do that. If they say they want a lotus birth, this is kind of how they want it done. So you deliver the baby, and then when the placenta is delivered, you put it in their container of choice and you give it to them, and they'll take care of the care. You can see here, this baby's at least a couple days old, because that umbilical cord that's coming out of the bowl, you can see it's dried up and sinewy. It's really leathery. It's dried off very nicely, and it will fall off naturally in about 5 to 7 days. So it was common in third world countries prior to hand washing not to cut at all. The practice was abandoned because it just wasn't practical. There are not enough studies in Western medicine to support or deny doing this. Most Western medicine obstetricians are like, it doesn't hurt anything. It doesn't help. Once that cord has stopped pulsating, it's not helping anything else, but it's not hurting anything. So if that's what they want to do, that's what they can do.
Hey, Janet, I got a question relating to that. Would there ever be a situation where it would be recommended to clamp and cut outside of the safety of the mom or infant, such as a dangerous environment?
If you've got a baby born to an opiate addicted mom and she is still high on drugs, yes, we do need to clamp and cut. If mom has been exposed to any chemicals that can go through the placenta, we clamp and cut. The ACOG, American Academy of Obstetricians, say, yes, immediate clamping and cutting would be for a baby who needs immediate resuscitation. As far as environment, I'm thinking rapid extrication, you've got a fire or a bomb or something. I can't think of anything extreme. If you're delivering a baby in a lousy environment, I'm going to put baby on mom's chest, and they're going to be one unit to me. And so I take mom with me. She's going to take care of baby. I'm going to take care of mom. Does that answer questions?
They say thank you. Yes.
Good, good, good. All right. So placenta delivery can take up to about 30 minutes. Usually most moms are delivering within 20 minutes. First time moms will be like, ooh, I'm starting to get crampy again. You know, they've never had this before. First question, are you having twins? Okay, because sometimes moms don't realize it. No, I promise there's only one in there. Well, it's probably the placenta coming out. Expect about 500 mils of blood. That's about a half a quart. It looks like a lot, but I promise that's expected, okay? We don't tug on the cord at all. We just kind of let it flop out on its own. Somebody with this picture lifted the cord to get a good picture, but do not tug on it. We're just going to let that placenta come out on its own. Note the time the placenta was delivered, because we need to know how long it took between baby delivery and placenta delivery. That's kind of an important thing to know. We need to know if this was a delayed delivery. So if the placenta is delivered and parents insist on a lotus birth, rinse the placenta with water and wrap it in a clean absorbent fabric that breathes. Cotton tea towel, some cheesecloth, something that has a lot of air moving around it. Wash it daily with fresh water to remove bacteria. Keep it covered with a breathable cloth, but do not seal it up in anything that is not breathable. If you put it in a Ziploc bag or a Tupperware container, it will start to rot very quickly, and it will draw flies and cats. So breathable container, it will dry up on its own. Some people are saying cover it with sea salt and herbs, and that will speed that drying process, and it covers up the smell and doesn't attract the flies and the cats. So postpartum emergencies, this is the meat of the presentation. This is where people are like, I don't know what to do once that placenta comes out. Like, you know, thanks a lot and you leave, or how's this going on? Okay, so we're going to start with fundal height. When mom delivers, immediately after her birth, her fundus will kind of shrink down to just above the belly button. And then 24 hours after birth, it goes to the belly button area. Okay, and then it will continue to shrink every single day until she is fully recovered. This is a very accurate picture of a mom who just had a baby. Hollywood does not depict them well. You know, these moms walk out of the hospital carrying a baby, which would never ever happen. But they've got, you know, really tight stomachs, their six packs are back, all this other stuff. It just doesn't happen. So moms are always going to have that post-pregnancy pooch for at least a month. Don't put any lesser expectations on moms for this. This is completely normal. As far as flow, it's called lochia. Okay, this is not a menstrual period, even though, yes, it is your uterine lining being shed. It's not a menstrual period because this lining is lochia. It was directly involved with the growth and delivery of a baby. Okay, so for the first 1 to 3 days, you're going to have dark red, heavy flow, possible clots. Okay, at about 4 to 10 days postpartum, that flow turns to a dark pink brownish. It gets very thin in consistency, almost watery. Okay, and at 11 through 28 days, it starts to turn a creamy brown, light yellow color, and it becomes mucousy-like. So this is totally normal. And moms, first-time moms who haven't read the books or anything, like, well, I've been on my period for 2 weeks. Well, you're going to be flowing for at least the next month. It won't always be blood. It'll be that postpartum flow. It'll be mucousy stuff. This is all normal. So for the first hour, check that fundus every 15, 20 minutes. Remember, mom delivers, that fundus goes down to a little above the belly button. Go ahead and check to make sure it is firm. It should feel like between a softball and a volleyball. Volleyball's a bit big. Softball's not big enough. I can't give you a good analogy of something that's in between those two sizes. But you want it to be firm and at the level of the umbilicus and midline, which means right in the middle. If it's off to one side or the other, mom needs to pee. That bladder's full and it's pressing that uterus over. So have mom go pee, check the fundus again, make sure it's firm every 15, 20 minutes. With moms who have had lots of babies or twins or triplets, basically think uterine stretched out a lot of times, okay? These moms have a hard time getting that thing to clamp down with every single pregnancy. So if you've had a mom who's had 4, 5, 6 kids, check that fundus frequently, because because that uterus just is resistant to have to stretch or to squeeze back down to its original form. The first hour is a lot. It's emotional, it's fatiguing, mom's hungry and thirsty, she's cramping, she's got a sore butt, she's got hemorrhoids, she's bleeding, there's clots, there's sweat, and it's overwhelming. So we're gonna go over a couple of these things just to help you reassure mom it's all normal, okay? So as soon as mom feels up to it, she may wanna lay there for an hour. By all means, she's exhausted. But if she says, I feel really gross, I'd like to take a shower, absolutely. As long as that placenta has been delivered, she's good to go. She can take a shower or a hot bath, put some clean sheets on the bed, put a towel or something down. She can take a nap. She may be ravenously hungry. I don't recommend getting her the big heavy pasta meal, okay? Light meal, light snacks, some cheese and crackers, a half a sandwich, some soup, a salad, not the big lasagna dinner, not the steak and potatoes, even though we want to celebrate. Heavy meals tend to sit really strong on mom's stomach. Remember, your digestive system has slowed down during pregnancy. The hormones that are causing that digestive system to slow down is still in your body. She just delivered, okay? So even though she's ravenous, offer her some light meals or light snacks. You may find that she eats a couple of bites and she's stuffed. Okay, and it also keeps her from throwing up. Encourage plenty of fluids. She's been sweating through this. She's lost a lot of fluids. She's probably hypovolemic. Lots of fluids, tea, juice, water, anything like that. You can offer Tylenol or Motrin for discomfort or cramping. And then she may be afraid of going to the bathroom. This is actually called bathroom fears. This is mom just squirted a kid through her vagina, and now when she goes pee, it burns. Or heaven forbid, she has to go poop because everything's stretched and torn down there. It stings. So moms usually have bathroom fears. You've got the perineal tearing, stretching, you've got hemorrhoids, all these things are going on. She's a little hesitant to do anything about it. So what we can do is encourage mom to drink plenty of fluids, and that will keep that urine dilute. She's like, I don't want to drink a lot of fluid because that makes me pee a lot and that's going to make it burn a lot. Yes, but you want that urine to be dilute. You got to drink. You've got to drink. So drink lots of fluids. It will keep the urine dilute so it stings less. It will also aid in keeping her from getting constipated. You can offer her gentle stool softeners. That would be milk and magnesia, some Colace, prune juice, something like that. None of this high-powered stuff. You don't want that. And that will keep the stool soft, so when she does have her first bowel movement, it won't hurt as bad. You can also offer a squirt bottle. Some moms, if you've got the shower head that's close enough to the toilet, you can actually turn the shower head on and have her point the shower head at her perineum as she's peeing and pooping, and that takes the sting out. That hot water feels good. You can also get a squirt bottle. This one on the right wasn't available when I had kids, which I think would be really cool. It's actually angled to hit everything the way it's supposed to. And it's beautiful enough to carry to the bathroom, which I thought was interesting. But get a squirt bottle, okay? Fill it up with warm water, nothing else. No soaps, no dyes, no perfumes. You don't need that. Just warm water. Have her squirt her perineum front and back, front to back also, and that will also help her feel fresher, and it will take that sting out of going to the bathroom. You can also offer a sitz bath. These are available at home medical equipment stores. The one on the top left is a pretty generic one. The pan sits in your toilet with the seat up, and then that hose is threaded through the back, and you fill up that bag with nice warm water. You fill up the tub of the sitz bath, sit in it until your butt's submerged by about an inch or two, and then turn on that water, and the water flows a constant warm stream along your perineum front to back, and it's pretty soothing to moms. This one on the bottom left is kind of a new thing, and it looks like they've got drain holes in the back. The flower petals are a nice touch. I don't recommend anything but hot water though. If you don't have anything fancy like this, get a big wash pan or a dish pan and just submerge your butt by about an inch or two in hot water, and that will take the sting out of things. This is also a new concept since I had kids. My baby's 22, so it's been a while. But these are called padsicles. Now, the one on the right is Instant Ice Maxi Pads. These are actually pre-made. You put them in the freezer. They have a gel in them that you can put in your underwear. Mom pulls them up, and that gives you an ice pack right there on her perineum. Really cool. But if you want to make your own, there's a Pinterest recipe for this. You take the big overnight maxi pads, open them up out of their package. You sprinkle just a little bit of water on there because remember, these pads are there to soak up the lochia. You don't want to saturate them already. You want them to do their job. So just a little light spritzing of water, fold them back up, put them in the freezer, and then when you're ready, you grab one, go to the bathroom, do your water bottle, pat dry, put one of these padsicles on, and then when you sit, whoo, you get a little ice pack action right there, and it takes the sting out. Now, the lavender oil on the side, that's a Pinterest picture. I don't promote anything else but water. If you feel like lavender would help you, you just do what you feel is best for you. So there is a new drive for maternal mental health awareness. The last several years, there's been a big push for realization that there's a lot of mental health problems out there, and then we're going to focus specifically on maternal mental health. Remember those hormones I was talking about? Moms are extremely emotional. There's postpartum depression, there's postpartum blues, and if it's severe enough, there's something called postpartum psychosis, where mom's hormones are in such a disarray that it's working on her brain, and she actually wishes harm to her baby or herself. Not in a good place. You know, these moms are not in a good place at all. So we need to recognize this. Hospitals are now talking with families of moms with their permission, families, partners, you know, baby daddies, anybody saying, hey, in case you forgot what this was like, or in case this is the first baby in the family for a while, we need you to understand mom's going to be emotional. There's going to be some crying, some laughing, some screaming, exhaustion, all these things all at once. And we need to monitor mom to make sure she's going to get over it. If she doesn't, we need to put her on some meds or some counseling. So for the postpartum emotions, that first hour or two for sure, hormones are surging. So you've got a high level of pregnancy hormones during pregnancy. As soon as that placenta leaves the uterus, there's no more pregnancy hormone being made. So these pregnancy hormones plummet over the course of a couple of days, okay? And then your exhaustion sets in. So now you're so happy the baby's here. Oh my God, this is amazing. We're laughing, we're crying at the same time. I'm exhausted, I'm hungry, it hurts down there. All these things all at once. And it can be so overwhelming because you can have 10 different emotions all at once and you can't put it into words. All you can do is sit there and laugh and cry at the same time. And that's normal. We need to assure moms it's totally normal. Absolutely. We may laugh and cry with you, but please don't shun them for saying, I don't understand why you're doing this, because that was the thought process many, many, many years ago. So the most emergent problems after delivery, we're going to go over a couple of them, okay, or actually 3 of them. That would be excessive bleeding, hypovolemia, and then anaphylactoid syndrome of pregnancy. So the first one I'm going to go over is excessive bleeding. It can be from a uterus that is not clamped down because it's tired of being pregnant, or it can be from a retained placenta or retained placenta products. That's what we call it, products or fragments, okay? So you've got this uterus that is floppy, okay? We've got to get it clamped down. As we are looking at this uterus and it's floppy, you've got bleeders, you've got veins in your uterus about the size of my thumb that are pouring blood into the uterus because it's supposed to be perfusing the uterus. And as long as that uterus is clamped down, that blood goes to the walls of the uterus, perfuses the uterus, we're all happy. But if that uterus is big and floppy, it's not getting perfused. Not only is it not getting perfused, it's actually diverting blood to the uterine cavity where it's just collecting. So the first thing you do is take the palm of your hand, put it between mom's pubic symphysis and her belly button and rub. Now, I'm not talking about a nice gentle tickle here. I'm talking about kind of getting in there. Rub, not as hard as you would for a shiatsu massage, but maybe like when you're kneading bread dough. You kind of got to get it in there, just a couple inches, and you're going to feel that uterus come up underneath your hand. It's going to create a big tight ball. If you want to, if you look between mom's legs while you're doing it, you're going to see gushes of blood and clots come out while you're doing this. And you're like, oh, it's normal. What you're doing is you're causing that uterus that is full of blood to tighten down, and now it's squeezing out what is in there. So you're squeezing out all that blood, all those clots, and now it's a firm ball underneath your palm, right underneath your umbilical, your belly button. Okay, it should be hard. Remember, a little bit bigger than a softball. If it's off to one side or the other, mom probably needs to pee. Make sure that thing is firm. If you're ALS, you can give oxytocin or pitocin, 10 units IM. If you've got an IV, you can put 20 units in a 1,000 bag of LR, open it up and monitor. Because here in a minute, mom's gonna go, oh my God, I've got a contraction. Yes, turn it down, titrate it down. This is not something that needs to be on a pump, okay? You're just gonna keep it at TKO. When you're doing a fundal massage, especially on a first-time mom, well, it hurts no matter what, but first-time moms don't realize this is gonna hurt. So make sure and tell mom, I've gotta rub your uterus, it's gonna hurt. What you're doing is you are inducing a contraction. So she doesn't like it when you do that, but you're gonna have to explain to her, I have to do this to keep you from bleeding to death, okay? With the IV, if you check again and she is still boggy, and that's what they call it, is boggy uterus, you can rub again, open up the Pitocin until you start feeling it firm up, close it back down again. You can also, if you're BLS or if mom really doesn't want an IV or an IM shot, have mom breastfeed. Because as babies latch onto the nipples and they start suckling, it causes mom's brain, the posterior pituitary, to release Pitocin, which causes that uterus to clamp down also. The second postpartum emergency is hypovolemia from exertion and blood loss. She's been in labor for who knows how long. She may have been sipping on ice chips, but she probably hasn't been drinking like she should because she's in labor. No one feels like drinking a bunch when you're in labor. And then you're sweating, and then you lose blood because you've just delivered a baby, so you can have hypovolemia. So during labor, encourage mom to take sips of fluid. Don't chug, because she'll throw up when she goes into transition. Just some sips of fluid, okay? After delivery, encourage mom to drink fluids. Non-caffeinated, non-stimulating, like water, juice, tea, anything like that would be wonderful choices. And then the last emergency I want to talk about is anaphylactoid syndrome of pregnancy. Now, this used to be called amniotic fluid embolus, if you remember hearing that one. And the thought process was, at that time, that an amniotic fluid embolus would get into your bloodstream and it would hit your heart and you'd go into this anaphylactic shock thing. Well, what they're actually finding out is it's an anaphylactoid syndrome of pregnancy. So you have a small amount of amniotic fluid that enters into mom's circulation and causes a cascade of events, okay? In amniotic fluid is baby's cells. The baby's fine little hairs, the lanugo, there's baby hairs in there, there's baby cells. If baby has a different blood type than mom, then mom's body sees those cells as a foreign body and it will go into this anaphylactoid syndrome, okay? The highest risk factors for getting amniotic fluid in the bloodstream is tears in the cervix during labor, having a C-section, or having amniocentesis or a D&C for a fetal demise or something. So risk factors for mom themselves is over the age of 35, if they were put on a Pitocin drip, if they have had multiple pregnancies in the past, if they've had uterine trauma, or if baby had meconium in the uterus before they were delivered. So the 4 classic signs of anaphylactoid syndrome of pregnancy is respiratory failure, altered mental status, hypotension. Bam, bam, bam. This is a BLS skill for assessment. respiratory failure, altered mental status, hypotension. If this isn't recognized soon enough, mom will develop disseminated intravascular coagulation, and it has a very, very high mortality rate. So why is it called anaphylactoid and not anaphylactic? Okay, anaphylactic reaction is a histamine-based reaction from something that you were exposed to previously, and it gave your body a chance to develop antibodies against it, so it's anaphylactic. Anaphylactoid is having a severe reaction against something that you've never been exposed to before ever. So that's the difference between anaphylactic and anaphylactoid. So again, this is the contemporary OBGYN journal. So you would see the diagnostic criteria is cardiopulmonary arrest or hypotension, respiratory compromise, and then DIC following those initial symptoms. It can happen minutes or an hour after the start of this, okay? 6 practical tips. Obviously, start high quality CPR if you need to. Put mom on her left side and do CPR, or move that uterus to the left while you're doing CPR to create a clearance in your aorta so they can get blood circulated. Give blood products, intubate, support basically your ABCs. However, here's what we can do before it gets that bad, okay? And it's called AOK. This is the evidence-based initial treatment for anaphylactoid syndrome of pregnancy. AOK. As soon as you detect these signs, remember, hypotension, altered mental status, respiratory failure, you give atropine anywhere from 0.2 to 1 milligram. You give ondansetron or Zofran, 8 milligrams, and ketorolac or Toradol, 15 to 30 milligrams, IV, bam, bam, bam. The cocktail of this together can stop that cascade of anaphylactoid syndrome of pregnancy. So one thing I always teach my paramedic students and my nursing students is if you're thinking about giving a treatment and you're wondering if it's going to help them, I want you to ask yourself, if I give this treatment and it wasn't what I thought it was, is it going to hurt them? So what if mom isn't in anaphylactoid syndrome of pregnancy and you go ahead and give her atropine, Zofran, and Toradol? Is it going to hurt her? No. Is it going to hurt baby? No. So this is a very safe thing to give if you are concerned about anaphylactoid syndrome of pregnancy. All right, I am going to get off here and see if I can get to chat. Are there any other questions, comments?
Yeah, there's a couple in there. What if you can give the first 2 but not the third? So if you can give the A and the O but not the K, do part of it or all of it?
Give what you can. If you don't carry Toradol, that's fine. Give the atropine and the Zofran and call ahead to your doc, your medical control, and say, this is what I suspect, this is what I've given, and get them to the nearest ER, and hopefully they can have that Toradol pulled up along with other things, and they can go ahead and give it, and it will stop that cascade.
Janet, can you put your last slide back up with your email information?
Oh, yeah.
Any other questions in here? Yes.
Can she say pathophysiologically what the atropine is doing for the mom?
Did you hear that?
Yes, and I can't. There are theories on why those 3 things work together, but it's theories, so it's not evidence-based medicine as far as proof. They know it works. They have an idea of why it works. I'm not sure I understand it, but I mean, if anyone else could chime in, if they have a better understanding of this, I would love to hear it because I don't understand it. I just know it works. I'm sorry, I don't have the answer to that question.
When the baby's born, it shows an MMO for their blood glucose. So in layman's term, what is normal for a baby newborn?
Newborn glucose.
Yeah, greater than 60.
Greater than 60.
Yeah, you want them vigorous. So even if I have a kid who is not vigorous, they're kind of laying there floppy and their sugar is 100, I'm still going to be concerned, why is this kid floppy? Are they used to having higher than average sugars because mom was a diabetic all pregnancy and that's low for them? Or do I need to bag them something else. But I want to see it at least 60. And if they are large for gestational age and they are a diabetic baby or mom was diabetic, I'm going to continue checking their sugar pretty frequently until I can get mom to breastfeed really good so we can get some glucose in their belly and keep that sugar up.
Okay, the fundal massage, isn't there another massage that they use to get the placenta out? It's not called a fundal, it's called something else, and they actually like dig into your uterus?
That is still done occasionally, especially in moms who are at risk for placental fragments. A fundal massage is the least invasive, it's the least painful, and it can be done by anyone. Only a physician can do intrauterine massage, and that's where they put a gloved hand up there and they literally scrape the uterus like this to make sure there's no fragments, and that uterus automatically, by being irritated from the inside, will shrink down. That hurts massively, but it's got to be done sometimes. I don't know what the name of it is, just intrauterine massage is all I've ever heard it.
Massage I was talking about. So it's kind of like you using the palm of your hand, but instead they use their fingers and they literally like dig like on your stomach.
Are you talking about externally?
Yes, externally.
Oh, I'm not sure I know what you're talking about. There's the regular fundal massage. There in severe emergencies, you climb on mom and you put your fingers on mom's uterus and you press down and in, but that's usually for shoulder dystocia. So I'm not quite sure I understand or if I even have the answer to that question.
Everyone is done with their questions.
Okay.
Sir.
What about perineum massage before? Hear you talk about that.
So the question is, we're going to do perineal massage or support to prevent tearing during delivery.
Sure. Yeah, it's called rimming. You can do home births, midwives will use olive oil, but you rub your fingers with a lubricant, warm water, olive oil, something, and then if this is mom's vagina, you would press down and kind of stretch and then use hot packs right here between mom's vagina and her rectum. You'd put hot packs there and you'd keep on stretching and get that stretched out really, really well. Occasionally you won't tear, but the tissue will separate just a little bit. We call it skid marks. Don't chart that. That's just an old term. But it's actually kind of separating the tissue, but it doesn't tear. Still stings a little bit, but you don't have any tears and it comes back together after delivery. But yeah, you can certainly do that if that's mom's preference and if that is within your protocols. Some states are like, no, that's unnecessary touching of the vagina. So some states don't do it.
All right, I think we get time for one more and we got to get the next speaker set up.
Sure.
No mas? All right, Jenny, can you put your last slide back up again just for a minute? And
It is.
showing. Oh, all we're seeing is your beautiful face.
Oh, crap. You see it now? Because I don't see me at all.
That's okay. I'll write it on the board. I'll get it.
Okay, yes, please. You can go to my website at emsteacher.com, or you can email me directly at Janet Taylor, 6 at iCloud.com.
All right, awesome. We will see Janet again after our lunch, right before her dinner, right?
Yeah, exactly.
All right, thank you.
Thank you, guys.
Thank you.